Thank you for listening to the National Award-winning PRS Journal Club podcast. I'm happy to present your hosts, Drs. Lily Mundy, Raj Parikh, and Kyle Sanniec.
Hi everyone, and welcome to the August 2019 edition of PRS Journal Club podcast. I am Lily Mundy, PRS Resident Ambassador from Duke University, and I am joined by my co-resident ambassadors, Raj Parikh from Washington University in St. Louis and Kyle Sanniec from UT Southwest. Today we have the honor of being joined by Dr. Justin Sachs, Associate Professor of Plastic and Reconstructive Surgery at Johns Hopkins University, where he is also the Director of Oncological Reconstruction. Thank you so much, Dr. Sachs, for joining us for this PRS Journal Club podcast.
Oh, thanks so much for inviting me.
The articles that we will discuss can be read for free on prsjournal.com, including an archive of all past Journal Club articles. The next article we will discuss is Sensory Recovery of the Breast Following Innervated and Non-Innervated Deep Inferior Epigastric Artery Perforator Flap Breast Reconstructions from the Netherlands. This is a prospective comparative study of all patients undergoing innervated or non-innervated deep flap reconstruction at a single institution. The authors recruited all women age 18 and older who underwent either unilateral or bilateral deep free flap breast reconstruction from January 2010 to July 2016 and underwent a clinic visit at their institution from September 2015 to July 2017 for sensory testing. They excluded patients who had bilateral reconstructions by unilateral reinnervation and patients who required a take-back to the operating room since the nerve coaptations were not routinely preserved during the take-back. An intercostal nerve from T10 to T12 was coapted to the anterior cutaneous branch of the third intercostal nerve. The anterior cutaneous branch of the third intercostal nerve was dissected for length by the authors, and the thoracic intercostal nerve from the flap was also dissected proximally until it joined motor branches, entering the rectus muscle to allow for primary nerve coaptation without using a nerve graft. After shaping the flap, the authors performed the primary end-to-end neurorrhaphy with 2 9/0 nylon stitches, followed by a drop of tissue glue. Sensory testing of the native and flap skin was performed with Semmes-Weinstein monofilaments with a calibrated application force ranging from 0.008 to 300 grams. Non-operated on breasts and unilateral patients were used as sensory references for normal breast sensation control points. Lower values corresponded to less pressure needed for the patient to detect the monofilaments and better sensation. Mean monofilament values were calculated for native skin, flap skin, and total skin. There were 364 patients who underwent deep flaps during their study period, with 81 of those patients included in the study. They had 36 patients with 48 innervated deep flaps and 45 patients with 61 non-innervated deep flaps. There were 27 unilateral patients with contralateral non-operated on breasts that were used as normal breast references. The mean follow-up was 15 months for the innervated breasts and 17 months for the non-innervated breasts. There were no additional differences between the groups. Surgical time was extended approximately 15 minutes for the innervated cases, and no complications were noted for this additional time. Figures 5 and 6 within the paper present a very nice graphical representation of the comparison of the sensation between the non-operated controls and the innervated and non-innervated flaps. Sensation improved with time in both innervated and non-innervated flaps. Innervated flaps had significantly better sensation than the non-innervated flaps, however, did not on average reach the level of sensation of a normal non-operated on breast. Innervated flaps did approach the normal sensation threshold on the Semmes-Weinstein monofilament reference values, and interpretation of the results ranged from diminished protective sensation to diminished light touch with protective sensation. The non-innervated flaps ranged from diminished protective sensation to loss of protective sensation. Both the flap skin and native mastectomy skin flaps overlying the flap had improvements in sensation for innervated deeps in comparison to the non-innervated deeps. However, the flap skin paddle had a greater improvement in sensation than the mastectomy skin flaps. Overall, this was a large study that compared sensory outcomes between innervated and non-innervated deep flaps with non-operated on breast controls. The value of the study is that it provides some objective differences in sensory recovery with and without flap reinnervation and provides a reference point for control. There are several limitations, however. The study was not randomized, therefore there may be an inherent bias in patients who chose to have an innervated versus non-innervated deep flap. The patients were also likely not blinded to their outcome, and while the monofilament testing should be objective, it's possible that the patient knowledge of their surgical status may have impacted how they answered. There was also variability in the timing of testing and length of follow-up. Additionally, there are several questions regarding deep flap reinnervation that remain unanswered by this study. The authors do not present qualitative sensory data such as temperature, pain, or erogenous sensations, and patient-reported outcome data is also not provided, so it's difficult to know how relevant or meaningful these sensory differences are for patients. So overall, while there's definitely room for continued study of flap reinnervation to address some of these unanswered questions, it does provide a large set of objective data supporting the use of flap reinnervation. So Dr. Sachs, I'd like to start with you and just hear what your thoughts are on the article and hear if these findings will influence your practice at all.
I think it was a very interesting and illuminating article that showed statistically with significance that there was perceived benefit of performing the neurorrhea and taking the skin and fat from the abdominal wall with a sensory nerve and connecting it to a nerve coming out of the recipient side vessel harvest area, and patients had perceived improvement sensation. So I think that there's without a doubt something to this. They were able to show between the two different populations, those without the nerve coaptation and those with it, that patients had reported an objective improvements in neurotization in the sensory distribution on the reconstructed flap. So I think that just taking this paper, looking for its sort of first principles, if you just compare the experimental to the control group, you actually have done something to improve the reconstruction of the breast. Now, it doesn't talk about how the patient perceives how the breast looks or how the partner appears to perceive the breast or anything like that. But what it does say is how the patient literally feels the sensation in the reconstructed breast. So I think that being said, the paper has some very unique value for those that are considering doing this type of reconstruction. And I think for a patient reading this who's interested in developing some type of neurotization of their breast in their skin paddle, then I think this has some validity to it that needs to be further explored.
Are you currently performing reinnervations for deep flaps at Hopkins?
Yeah, great. At Johns Hopkins, I'm a busy microvascular surgeon. I do head-to-toe cancer and trauma reconstruction, and a significant portion of my practice is breast reconstruction. A little bit different than this study is I do a lot of autologous reconstruction following nipple-sparing mastectomies. So my practice is a lot of staged reconstruction where patients have prepectoral tissue expanders placed, and then they come back and usually have implants or autologous tissue. So I will perform nerve reconstruction for patients that request it. So a lot of patients come in looking for this type of reconstruction. I don't routinely offer it. There are other partners in my practice, specifically Gedge Rawson, who actually was a fellow with Lee Dellin, who is on faculty also as a voluntary faculty at Johns Hopkins. He wrote the original article with Sherry Slazak on neurotizing the pedicle tram from the abdominal wall. So Gedge Rawson offers neurotization to a majority of his patients. I think, more often than I do, but I will routinely perform them for patients who request, and that's my practice. I'm waiting to see what the hopefully level 1 evidence at some point will show us, because we can get into it a little bit more about, in this paper they did primary nerve coaptation, so they didn't talk about using nerve grafts. So I think if we get into it a little bit more, doing a primary nerve coaptation with a short nerve coming off the abdominal wall from the intercostal branch and then coapting that to a branch off the intercostal nerve without a nerve graft, in my practice is a little bit more challenging. And not to say that in this practice in the paper they do this routinely, but I think just in my experience, if we're going to do this, we're going to do this with a nerve allograft.
That's been the experience that I've recognized at Duke also, this has mostly been per patient request. We're not really certain based on the other evidence that we've had, not sort of still waiting to see before we start to offer this routinely to all patients. And our surgeons have also used allograft. And so I thought that was interesting that the authors were able to do this without and only extend their surgical time by 15 minutes. As you mentioned, they didn't include additional patient-reported outcome data. I don't know how much this has influenced how they're able to, shape their flap or their overall reconstruction. But Raj and Kyle, what were your thoughts on the article and what has been your practice at your respective institutions?
Sure, thanks Lily. This is Raj. Yeah, so at WashU, we love nerves, but in this patient population in breast reconstruction, we still don't have a majority of our patients undergoing neurotization for DIEPs. We have started doing neurotization for the native skin flaps in tissue expander and prosthetic breast reconstruction, just kind of in a trial method currently, but that's just a few patients. Similar to what you said, Lily, if patients ask for it and they're really critical about it, then obviously, we'll try it. I think the difficulty is just like what Dr. Sachs said, is in our population too, we do a lot of nipple sparing mastectomy reconstructions. And obviously in that patient population, I think the value of this goes down. Also, when you don't have a large skin envelope and a majority of it's going to be buried and deepithelialized, that also the value goes down. And then I think really some of the hesitation is just the studies that are out there and the lack of follow-up and long-term data. And I think while this study was great, it suffers from some of those same exact limitations that the previous studies did, which is the follow-up is still not longer than 24 to 36 months. They still haven't, even though they show a statistically significant difference between neurotization versus non-neurotization, it's hard to tell if that's a clinically meaningful difference. And I think that's the important thing for patients, is this a clinically meaningful difference? Because while it approaches their normal sensation on the contralateral side, it doesn't actually get there currently. And, over time, I'm sure it will, but those studies aren't out there. So I think that's the key, is there a difference in erogenous sensation? Is there a difference in what patients perceive as valuable, and does it impact their satisfaction overall with the result? I will say, from following some of these patients for several years now, it's not that common, and Dr. Sachs, I'd love to get your thoughts on this, but it's not that common for patients, at least in our population, with smaller skin paddles to come back and complain of sensation in their deep reconstruction. So I think that's a big thing too, is that this doesn't seem to be a large problem, at least in our patient population, and maybe it is in different places where patients are more sensitive to it. So I think those are all my thoughts in the paper and some of the differences between what we do at WashU. And I would think that, eventually if the trend with patients seems to be towards favoring sensate reconstructions, then we would obviously shift our practice. But currently, there doesn't seem to be that high of a demand outside of a few occasional patients.
Hey Raj, you brought up the concept of doing nerve reconstruction in the mastectomy and tissue expander patient population. Is that being done with an allograft?
It's been, an intercostal directly, and sometimes an allograft, depending on the length, but sometimes directly coapted to the skin. So Dr. Tung's doing it where, and I think he talked to Dr. Paul Soderno about this, and similar to the concepts of RPNI, but instead of, often what we find is in the immediate mastectomy is that, unless you're present for it, is that a lot of those nerves are just kind of blown through. So able to do a primary repair coaptation is very difficult. And if you don't want to add significant operative time, so what we'll either do is take an intercostal, and if it reaches, just put it underneath as basically a dermal cap. So we just core out a small area, either under different, like 4 or 5 different spots, and then branch it. And if we have to use an allograft, we will, and then branch it basically so it sprouts out into 4 or 5 different spots underneath the dermis, and then we just seal it or put some fiber and glue underneath it. And then the thought is, and there's really preliminary data, one of my co-residents presented it at the PSRC meeting this year, but it's just very few patients currently that we have more than a few months of data on, but it seems to be helping a little bit. Obviously it's too early to say whether it'd be beneficial long term, but I do think an allograft in a lot of these cases is necessary.
In my practice, our practice, patients are coming in requesting it. It's not 100% of the patients, but it's definitely more than a handful. So we offer it when they request it. I think I've seen many of my patients with nipple-sparing mastectomies, free flaps, without any neurotization, regain pain, light touch, temperature in that order. And some patients have even had some nipple sensation return where they are surprised by it. I've also had a lot of patients with pain across the mastectomy flap over time as they sort of re-neurotize. That just shows you that the body is sprouting nerve fibers. I think some of the things that will be important to look at is what happens over time if you neurotize the flap and you deepithelialize it and you place it below the mastectomy flap. Do you get better return of pain, light touch, and temperature in a quicker fashion than you would if you didn't do anything at all? And I think those are the studies that need to be done. This approach is not something with great morbidity in the sense that you can harvest the intercostal nerve from the abdominal wall with the perforator. When you harvest the mammary vessels, you can dig out the anterior branch of the intercostal nerve. And then a nerve graft, if you choose to use it to help you with the inset, so it's not tight or doesn't tear, a nerve graft, although it costs money, there's no morbidity to opening up a nerve graft and placing it on the chest wall. So I think that, if you take everything into consideration, if everything was free and you wanted to return both form and function, then the idea of really studying this to understand if you can get sensation back better than you would if you didn't do any primary neuropathy or nerve graft and neuropathy is something that we should explore. And I think that, this paper, although it's skin-sparing mastectomy, and it did say as they followed both sets of patients, both experimental control out over time, that they both got better. I think that they showed that the neuropathy improved the sensation, and I think that when you're dealing with young women who've had their breasts removed and are childbearing age and have spouses or partners or want to have erogenous feelings, I think it's up to us to literally and figuratively push the envelope and offer this to patients and study it, with investigations and validated studies with good endpoints, really good endpoints and good devices that measure outcomes, sensory outcomes. So I think that it's a good paper, and it actually asks a lot of questions and helps us think about more studies to design.
Definitely. Kyle, what were your thoughts?
At UT, they've done more and more of the nerve coaptations. We explained to the patients beforehand that the primary goal is to get a reconstructed breast, so that's the first and foremost goal, and a secondary goal, if we have nerves available, we'll try to coapt them. We usually, when I've done it, I've never been able to get enough length that I could do it primarily, and so normally we're using nerve allograft. The other question I had on the study, and just in general, is I think Raj really hit the nail on the head of there are things that are statistically significant, with these Sims-Weinsteins, and there's objective data that says there's better sensation, but does that actually matter to the patients in terms of their clinical sensation? Are they actually feeling the breast more? And even when you look at the data, they still don't have protective sensation. One of them had diminished protective sensation at the best, and that's not really what you're looking for. And similarly, most of ours are nipple sparings, or very rarely do we have a really big skin paddle up there. So how much of that nerve sensation are the patients actually able to really feel and understand when all they have is this little small slip of skin at the inferior part of the breast that's exposed?
I think something that was really interesting was how they broke up the areas that they did the testing. They looked at the mastectomy skin flaps, and they found some improved sensation in those mastectomy skin flaps that were overlying, deepithelialized skin paddle from the flap, which I thought was really interesting, showing that maybe some of that neurotization is then growing up through the deepithelialized skin into the mastectomy skin flap. But I know that Dr. Kuijk and the BreastQ team is working on developing new BreastQ modules for breast sensation, so I think that will probably be really important in our further study and exploration of this issue, since it will really allow us to tell, how much this actually matters to patients, as opposed to, yes or no having improved sensation.
Just to throw in a thought about this, because I know that in the United States, I'd probably say that from the centers that I know are doing breast neurotization, they're using a nerve graft. At your centers, for those that are doing this, would you say that we're all using Allograft for neurotization at Duke and Wash U and UT Southwestern? Would that be more of the case or less of the case as a group? What do you think?
More of the case.
More of the case.
I'd say more of the case.
So one of the things I did while I was busy operating nonstop for the last decade at Johns Hopkins was I got my MBA. And one of the courses we took was microeconomics, which is the allocation of scarce resources. So, President Trump just signed an executive order that says that he would like transparency in healthcare dollars. So you'll be able to go to a hospital and find out what everything costs. So these nerve grafts are not cheap at all. And these nerve grafts cost thousands of dollars. And when you're talking about what does the case even bring in for the hospital, this is important to, as a risk-benefit analysis on a financial model. If you're using two cadaveric allograft nerves for breast reconstruction, these are going to cost money. At some point, this operation might not even be a choice of plastic surgeon. This might be a choice of the hospital saying to you, if your patient would like it, they will have to pay for it out of pocket. And I don't know what anybody's thoughts, especially all three of you are going to be going out to practice pretty soon. These are the things now that we have to think about. Every case I get now, I receive an itemized list of the cost of goods for the operation that I perform. And I think that it's important that we have very strong clinical studies with good endpoints of clinical outcomes that prove that this actually is doing what it's supposed to do as we justify the expenses of healthcare moving forward. So just to throw that out, because they cost money, the grafts, the nerve allografts, and then the other way to get it is by cutting the patient in the leg or the arm and taking sensory nerves, which come with physiological and financial costs too.
Yeah, definitely, especially as we start to think about all of the products we are now using in breast reconstruction, especially staged reconstruction in patients who are getting different cadaveric products, with tissue expanders and getting staged for the reconstruction, having venous couplers, Cook Dopplers, other monitoring devices, like this will just be one more thing in that list.
We might have to make the decision of what we can do and what we cannot do. Now, if patients will pay for this, then they pay for this. But if third-party providers say, show us the data, they're going to ask for that. I don't specifically know if it's deemed experimental at this point, but it's definitely a procedure that probably needs to be studied at a highest level of evidence in order to justify third-party payer reimbursement.
Yeah, you mentioned this before, but one of the great things about this article is it really helps us ask, additional questions and kind of look for what we need to better study this topic. And I think with that, we'll end the discussion of this article. Thank you, everyone, for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us on the Apple iTunes Store. Also, remember to tune in to the other 2 articles that we'll be discussing on this month's podcast. Finally, please join us for our monthly journal club on Facebook, where we will be able to interact directly in real time with this month's selected articles' authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not done so already. It is there where our monthly journal club takes place. And once again, thank you so much, Dr. Sachs, for joining us.
Oh, my pleasure. Thank you for having me.
Thank you for listening to the award-winning PRS Journal Club podcast. Be sure to read all of the articles being discussed, including some of the classic pairings from the archives, for free on prsjournal.com.